Muy buenas tardes a todos. Es realmente un placer darles la bienvenida a esta sesión. Mi nombre es Ignacio Leiva y vengo de Chile. Trabajo como activista y defensor de la reducción de daños y hoy tengo el gran honor de moderar este panel. Primero que todo, quiero agradecer sinceramente a la organización de HR25 por brindarme esta oportunidad. También aprovecho este momento para decir que veo esta invitación como un reconocimiento al progreso que hemos logrado en Chile, especialmente en la creación de una regulación justa para los vaporizadores y en la promoción de alternativas más seguras para las personas que usan nicotina. Aún no es perfecto, pero demuestra que con esfuerzo y persistencia el cambio positivo es posible. Además, estoy muy contento de que este año se haya comenzado a abrir este maravilloso espacio de discusión y aprendizaje para la reducción del daño relacionado con el tabaco. Era algo que hacía falta y es un verdadero honor de ser parte de esta apertura histórica. Creo firmemente, como muchos de ustedes, que todas las partes interesadas deben tener la oportunidad de ser escuchadas en este esfuerzo para construir soluciones realmente efectivas y justas. Y para ser honesto, cuando comencé a trabajar en reducción de daños, muchas personas me dijeron que era imposible crear políticas justas. Además, existía, y lamentablemente todavía existe, mucha desinformación sobre lo que hacemos y por qué lo hacemos. Pero seguimos adelante, construyendo nuestra comunidad, enfocándonos en la evidencia científica, los hechos y las experiencias reales de las personas. Y hoy puedo decir con orgullo que hemos logrado avances reales. Cada paso adelante importa. Esta será una sesión rápida, lo que significa que tendremos presentaciones breves y concisas, y haré todo lo posible para mantener todo en movimiento de manera fluida y puntual. Cada orador tendrá cerca de 7 minutos y luego de todas las presentaciones abriremos un espacio de preguntas del que espero participen activamente. El objetivo de hoy es compartir experiencias prácticas y perspectivas de diferentes partes del mundo, enfocándonos en estrategias de reducción de daños tanto para la regulación del cannabis como el tabaco. Tenemos un panel fantástico de oradores, cada uno aportando perspectivas únicas desde sus campos y países. Como moderador, mi rol es ayudar a guiar la conversación y asegurarme de que estas voces importantes sean escuchadas claramente. También haré lo posible para traer energía a la discusión, porque realmente creo que la reducción de daños merece toda nuestra pasión y atención. Muchas gracias nuevamente por estar aquí y vamos a dar comienzo con nuestro primer speaker, Dr. Anthony Salandy. Doctor, no, I need to introduce you. Dr. Anthony Salandy is Chief Programmer and Business Strategy Officer at the National Harm Reduction Coalition. With over 30 years of experience, he focused on practical strategies to integrate tobacco harm reduction into harm reduction services for people who use drugs, such as syringe service programs and overdose prevention sites. He will share evidence-based strategies, barriers, and success in implementing tobacco harm reduction at the community level. You can start whenever you want, Dr. Anthony. Thanks to be here with us.
Thank you very much. Again, my name is Anthony Salandy. I'm the Chief Program and Business Strategy Officer at National Harm Reduction Coalition. And my task today is to talk about practical strategies and approaches to support THR, tobacco harm reduction, integration into traditional harm reduction services. I have 7 minutes, so I'm going to sort of go through this really quickly. And so just to sort of ground us, tobacco harm reduction is a public health strategy with the goal of minimizing negative health impacts of tobacco use, particularly individuals who are unable or unwilling to quit smoking. The goal is to shift smokers to less harmful alternatives, such as safer nicotine products like e-cigarettes, heated tobacco, snus, nicotine replacement therapy, gums and patches, and medication like Chantrix and bupropion, rather than trying to eliminate nicotine use altogether. This is just a summary. I just wanted to point out that tobacco harm reduction is not a smoking cessation. In fact, we try to say from the jump that it's not a smoking cessation program. especially to individuals who are working in SSPs, who will be trying to train and trying to integrate the programs. Okay, so why talk about tobacco harm reduction? Globally, 8 million people die from combustible tobacco-related illnesses each year. And I think it was, Stacy said this earlier today in her talk, that what's really important to understand is that the underlying principle that nicotine itself, while it's addictive, is not the primary cause of smoking-related diseases. Rather, it's the combustion process and the resulting toxic chemicals that cause most of the health-related problems. Also, there's substantial research that says smoking cigarettes is common among users of other substances, especially cocaine, meth, and heroin. This is just I'm not going to go through the data, but this is some data supporting that. So should THR be part of services offered by HR orgs? Yes, absolutely. I think that how syringe service programs really have a responsibility to take a look at the whole person when they're trying to deliver their services. And so it's absolutely necessary, but there are some obstacles to that. How many more minutes do I have there? 3? Okay. Oftentimes, if you take a look at health ministries and health departments, both in the United States and low income and low and middle income countries, oftentimes tobacco control is separate from opioid prevention programs. And that sort of distancing in programming and funding causes it's a lack of let me say that programming that's available to address smoking with people who use drugs. Disparities especially in LMICs, THR products cost more than cigarettes and are less accessible. And in case of Mexico, there was a constitutional amendment to ban vapes and e-cigarettes. So there is sort of like a pushback again for the accessibility of THR products. Harm reduction organizations and syringe service programs may lack resources to adequately and ethically address smoking among their program participants, and this is extremely important. We can go to SSPs and tell and train the SSP workers about THR, right, and help them engage with their program participants. But unless we provide the SSPs with the resources to sustain that effort, they just can't do it. They don't have enough resources to do it. Big tobacco can be seen as co-opting harm reduction movement and harm reduction spaces. We've heard that National Harm Reduction Coalition has a program, a THR program that's funded by Global Action to engage harm reduction organizations around learning about THR and integrating it into their traditional harm reduction services. We've got a really good reception across the US about it, but there are few individuals or few organizations that are pushing back, saying how that tobacco harm reduction, trying to integrate into a traditional harm reduction is big tobacco trying to co-opt the movement. So we still have that sort of, issue. And then staff at SSPs and harm reduction organizations, they may also smoke cigarettes. In fact, some of the research that we've been doing, some of the qualitative research, we are finding about 50 to 75% of individuals that work at syringe service programs and harm reduction organizations at the community-based level actually smoke cigarettes on a regular basis, combustible tobacco on a regular basis. So there's that education that needs to happen with SSP workers around alternatives to combustible tobacco. I'm going to, I have 2 more slides, but it's the end of the time. One of the things I just want to leave you with, what we're finding at NHRC as we go through this THR integration is the importance of working with organizations to do an assessment of their staff to see their level of understanding of tobacco harm reduction. That is a critical part in our activities in terms of providing technical assistance and capacity building to SSPs to get them up to speed on tobacco harm reduction. Thanks.
Thanks a lot, Doctor, for your presentation. A big clap for him. Thank you. Bueno, nuestra siguiente presentadora es María José González. María José es antropóloga, educadora no formal y una mujer centroamericana usuaria de drogas. Trabaja en reducción de daños basada en pares y hablará sobre la urgente necesidad de estrategias de reducción de daños por tabaco en Costa Rica, donde las políticas centradas en la abstinencia tienen un impacto limitado. Resaltará la necesidad de expandir el apoyo a las personas que no pueden o no desean dejar el consumo de tabaco. Muy bienvenida, María José.
Hola, buenas tardes. Bueno, como ya mencionaron, soy una mujer centroamericana y usuaria de drogas, y hoy lo que quiero compartir son algunas reflexiones sobre una de mis favoritas quizá, que es la nicotina. También tengo que mencionar que el tabaco es de pronto la sustancia con la que he tenido una relación más problemática. Hace ya más de una década que comencé un proceso para reflexionar y actuar sobre el vínculo que estaba sosteniendo con esta sustancia, y pues en ese momento en mi país encontré un contexto que, si bien promovía la prevención y la abstinencia, dejaba muy pocas alternativas más allá de la abstinencia, lo cual para mí no fue nunca sostenible ni lo es a la fecha. A ver, ¿ahí me escuchan? Bueno, a partir de este proceso personal es que surgen algunas dudas que alimentan la investigación que hoy voy a compartir de forma muy breve. Estas dudas también dieron lugar a un esfuerzo realizado por pares, por personas que usamos tabaco y nicotina, para precisamente comprender las limitaciones, las posibilidades y los alcances de la reducción de daños en tabaco y nicotina en nuestro país. En Costa Rica, como en muchas otras sociedades latinoamericanas, el tabaco tiene una raíz histórica y cultural profunda, desde usos tradicionales indígenas hasta la industrialización moderna. Ha sido parte del tejido social. Sin embargo, después de 2008, con la ratificación del Convenio Marco de Control de Tabaco y la normativa que se desprende, pues vemos un enfoque más bien restrictivo y que limita las oportunidades de información o educación sobre productos de tabaco o nicotina. La investigación que desarrollamos, bueno, desarrollamos una encuesta durante diciembre de 2024 y enero de 2025. No sé si me ayudas con para pasar la diapositiva. Y ahí obtenemos alguna información importante sobre las personas usuarias de tabaco y nicotina que participaron, y vemos que, por ejemplo, el 55% ha considerado modificar su relación con el tabaco y la nicotina, pero que también un 66% de esas personas no cuenta con información para tomar decisiones sobre su consumo. Y lo más preocupante es que vemos que un 89% de las personas no ha recibido nunca información de reducción de daños en tabaco y nicotina por parte de personal de salud. Estos datos los profundizamos también en grupos focales, donde participaron de nuevo personas usuarias de tabaco y nicotina, pues quienes coinciden en señalar información sobre los productos de tabaco y nicotina que consumen, y también sobre estrategias de reducción de daño que le permitan pues agenciar esa relación que tienen con el tabaco. En Costa Rica, los sistemas electrónicos de administración de nicotina o vaporizadores son legales desde 2021. Sin embargo, sí ha habido una estrategia de restricción de la información, como ya mencioné, Y pues otros productos conocidos, como mencionaba en la ponencia anterior, como el snus, las bolsas de nicotina o incluso la terapia de reemplazo, no son accesibles según la percepción que logramos obtener de las personas participantes en el estudio. Además de eso, pues tengo que mencionar que datos de la encuesta global de tabaquismo en adultos, para el caso de Costa Rica, indican que de 8,7% de prevalencia en 2015 baja a 8,5% en 2022. Es decir, después de una década de políticas restrictivas, el impacto ha sido más bien mínimo, ¿no? Además, bueno, es preocupante que de forma paralela el comercio ilícito de cigarrillos ha crecido. El Observatorio de Comercio Ilícito estima que durante 2024 el 46% de los cigarrillos comercializados en el mercado ilícito, provienen del mercado ilícito. Y también toman una muestra de 28 cajetillas del mercado ilícito y en un 75% se encuentran trazas de madera. En este sentido, el riesgo es aún mayor para las personas más vulnerables o con un menor poder adquisitivo, que además carecen de información. Bueno, de forma preliminar, algunos hallazgos de la investigación revelan principalmente que aunque existe un marco normativo que protege la salud pública de quienes no consumen tabaco y nicotina, este mismo marco normativo ha dejado en vulnerabilidad a quienes deciden seguir consumiendo o incluso a quienes buscan alternativas de consumo menos riesgoso al tabaco. A ver, ¿cómo andamos de tiempo? Bueno, sabemos que en materia de regulación de drogas, la regulación es un paso importantísimo que nos ayuda a prevenir, por ejemplo, la criminalización o las detenciones arbitrarias. Sin embargo, el caso del tabaco y nicotina en Costa Rica también es un indicativo de cómo estas políticas, sin una integración de reducción de daños, pues siguen fallando para las personas consumidoras, y siguen dejando la abstinencia como única alternativa en salud, lo cual para muchos de nosotros y nosotras no es sostenible. En ese sentido, quisiera retomar entonces algunos elementos claves que considero para pensar una reducción de daños en tabaco y nicotina en Costa Rica, que finalmente parte de reconocer y respetar la autonomía de las personas para tomar decisiones informadas sobre su cuerpo y su salud, ¿no? Algunos elementos pues tienen que ver con proporcionar información basada en evidencia para las personas usuarias y fomentar la socialización de esa información entre pares. Asimismo, consultar a las personas usuarias sobre sus necesidades reales y encontrarlas donde están, garantizar un espacio en la mesa sobre aquellas decisiones que les afectan directamente, facilitar el acceso a productos de riesgo reducido o de menor riesgo, como los que ya fui mencionando. Y bueno, también reconocer el contexto sociocultural e histórico del consumo de tabaco en América Latina desde una perspectiva interseccional y de justicia social. Quisiera, ir terminando nada más, reconocer que el conflicto de intereses, esta es una investigación financiada por el Tobacco Harm Reduction Scholarship Program, que a su vez recibe financiamiento de Global Action to End Smoking. Y tengo que mencionar también que ninguna de las organizaciones participó en la planificación o ejecución de la investigación. Y yo me gustaría quedarme por ahí. Gracias.
Muchísimas gracias, María José. Me gustaría hacerte una pregunta. ¿Qué lecciones podemos aprender de países que han integrado la reducción de daño en sus políticas de control de tabaco para disminuir el consumo de cigarros combustibles?
Países como Suecia, por ejemplo, que ha implementado y fomentado la transición a productos de riesgo reducido como el snus y que ha logrado reducir la prevalencia de consumo de tabaco a un 5%, ¿no? Nos deja también una línea clara de por dónde podríamos promover una estrategia de reducción de daños desde estos productos de riesgo reducido que mencioné. Tenemos el caso de Inglaterra, por ejemplo, ¿no? Con el programa Swap to Stop, donde se garantizan o se facilitan productos como vaporizadores a personas adultas que usan tabaco como una estrategia de salud para reducir el daño. Entonces considero que son experiencias a las que podríamos volver a ver y aprender para el caso de Latinoamérica.
Muchísimas gracias, María José. Nuestra siguiente ponente es Ivana Rodrigues Vaz. Ivana es enfermera y cofundadora de la Asociación de Cannabis Flor do Sertão. Abordará el rol de las enfermeras en la promoción del uso de cannabis medicinal en Brasil, donde las lagunas regulatorias dejan a los profesionales de la salud sin directrices claras. Ivana hablará sobre la necesidad de protocolos y educación para mejorar la atención a los pacientes y superar los prejuicios contra el cannabis. Muy bienvenida.
Hola, everyone. I'm truly honored to be here in Bogotá. And this powerful space for dialogue and transformation. My name is Ivana Rodrigues. I'm a nurse. I'm from Brazil, Recife, Pernambuco. And I'm here to share some reflection on the role of nurses in promotion the safe use of medicinal cannabis in Brazil, and how this intersects with the harm reduction, health, justice, and care. The legal path of cannabis, por favor, la seguinte. The legal path of cannabis in Brazil has been marked by contradictions and slow progress. Back in the 16th century, cannabis was already began use for medicinal purpose, but in 1961, Brazil adopted international prohibition rules from the United Nations Single Convention of Narcotic Drugs, and cannabis became a symbol of criminalization and marginalization. Then things began to shift. In 2006, Brazilian's drug law maintained criminal penalties for trafficking, but introduced a blurry distinction regarding personal use. In 2015, Brazilian health regulatory agency, Anvisa, authorized the import of cannabidiol-based products. By 2019, with the Resolution Collegiate Board of 327, national production was permitted under regulation. In 2024, a historic decision by Brazilian Supreme Court discriminalized possession of up to 14 grams. And now, in 2025, Anvisa is reviewed the regulation with input from the public. So, we're facing a transition from punishment to care. But there's still a lot about, especially when it comes to professional practices. In this legal and political landscape, we can't overlook the importance of Brazilians' unified health system, the SUS. It's one of the largest public health systems in the world, based on principles of universality, equity, and comprehensive care. With SUS, nurses play a fundamental role in primary health care. They provide clinical consultations, prescribe with official protocols, request exams, coordinating care and education communications. That's why we developed this study. Our objective was to investigate how nurses can contribute to the safe use of medicinal cannabis. We wanted to understand their role, their challenges, and what structural changes are needed for nurses to be part of these conversations with legitimacy, safety, and recognition. To explore this, we conducted an integrative literature review. We searched for major databases, the Virtual Health Library, Cielo, CAPS, and Medline. We selected studies published from 2019 and 2024, focused on nursing and cannabis. Out of 33 initial results, 9 studies meet our criteria and were analyzed in depth. Most studies were published in foreign languages and only one study in Portuguese. This approach allowed to map not only current practice, but also acknowledge gaps and points of tensions in the field. The results of the review were very revealing. On one hand, nurses are already contributing in key ways. They offer guidance to patients and families. They monitor the therapeutic effects and possible side effects of cannabis treatments. They participate in advocacy efforts, especially regarding safety, environments, and access to health technologies. But on the other, we found serious obstacles. There are no official clinical guidelines for nurses' work. No. Yes. But on the other, we found serious obstacles. There are no official clinical guidelines for nurses working with medicinal cannabis. The topic is not part of most nurse curricula in Brazil, and due to legal ambiguity and social stigma, many professionals still feel insecure or unsupported when dealing with this subject. In short, we're dealing with a gap between practice and policies. Nurses are on the front lines, but the system hasn't caught up. Medicinal cannabis is already part of the clinical reality in Brazil, and the number of patients using cannabis-based therapies continues to grow. Yet, nurses are still invisible in this regulatory debate. To change that, we needed to take some urgent steps. First, we needed to integrate cannabis education into undergraduate and continuing training for nurses. Second, we must develop clear evidence-based clinical protocols that guide safe practice. Third, we have to guarantee legal protection and ethical backing for professionals who are already doing this work in practice.
1 minute left.
Yes. Nurses is care in action. It's technical, it's relational, and it's political. If you are serious about harm reduction, safe access, we need you to recognize the centrality of nurses in the process. Nursing is not necessary. It's a pillar. And where there's care, there should be presence, training, and voice. Thank you so much.
Thanks a lot, Ivana. That was super nice. And now we have two speakers in the price of one. Now we will listen Natalia Gutierrez y Laura María Bernal. Natalia Gutierrez tiene más de 20 años de experiencia en salud pública, enfocándose en poblaciones vulnerables. Laura María Bernal trabaja como directora de proyectos en GRIP en el proyecto Enlightened Height, relacionado con las directrices actualizadas sobre el consumo de cannabis de bajo riesgo para jóvenes consumidores de cannabis en Montreal. De 2019 participa activamente en el campo de la reducción de daño a través del proyecto BOSCAN, una iniciativa bilingüe de educación sobre la cannabis para jóvenes, como ya dije, en Montreal. En su presentación conjunta explorará los desafíos de adaptar las guías de consumo de cannabis de bajo riesgo de Canadá para adultos jóvenes. Presentarán resultados de los grupos focales con usuarios de cannabis, abordando la confusión sobre el contenido de THC, el acceso al mercado legal y a la importancia de involucrar a los propios usuarios en el desarrollo de las guías. Ambas compartirán los 7 minutos asignados para su intervención. Por favor, adelante.
Gracias, Ignacio. A pesar de que nos presentaron en español, la presentación será en inglés. Entonces, buenas tardes. Good afternoon, everyone. I'm Laura María Bernal, a project manager at GRIP, and it's an honor to be at this concurrent session with my colleague Natalia Gutierrez from Montreal's Public Health Department to present the Enlightened High Challenges in Tailoring Updated Lower Risk Cannabis Use Guidelines to Montreal's Emerging Youth. So we are co-presenting, given the collaborative nature of this project, as you will see in just a moment, and we can go to the other. Gracias. So for a bit of context, in 2022, 5 years following cannabis legalization in Canada, the lower risk cannabis use guidelines were updated based on new scientific evidence published by Benedict Fisher's research team. As well as, it is important to note that in Montreal, 18 to 24 years old, which we refer to as emerging adults, are the age group with the highest proportion of cannabis users across the general population. So in this context, GRIP, a community-based harm reduction organization alongside Montreal's Public Health Department and researchers from the Institut Universitaire sur les Dépendances and the Université de Montréal came together to review and adapt cannabis harm reduction messages based on these updated guidelines to emerging adults, which constitute our target audience. And with the end goal of disseminating a bilingual toolkit in both French and English across youth spaces. So the methodology we followed to tailor our cannabis harm reduction messages was to carry out an online survey and 2 participatory review phases in the form of focus groups. So first, the online survey aimed to assess youth's perception and exposure to Montreal's 2019 guidelines and to gather preliminary feedback on the updated messages. And a total of 119 participants completed the survey. And from there, we reviewed and translated the updated guidelines and we held a first round of focus group discussions. The objective here was to assess youth's understanding of the updated guidelines and their perceived relevance and applicability. So based on this feedback that was collected during round 1, we reviewed our updated messages once more, this time with a special focus on health literacy. And in January 2025, we held our final round of focus groups to review and approve the proposed messages, graphic design, and dissemination strategy. In both rounds of focus group discussions, we had 33 participants, so a total of 66 youth that were consulted during the project. And before I give the mic off to Natalia so that she can introduce some of her findings, I'd like to share some of the visuals that we created based on the feedback gathered from our target audience. So the result is the Enlightened High, which is a bilingual cannabis harm reduction toolkit, which includes a total of 15 digital visuals for social media, 1 physical poster, which I have a copy of here. If you'd like, I can share it around in a bit. And supporting documents, which will be found on our webpage in the month of May, when the full toolkit will be launched. But our youth focus launch took place on April 20th during Montreal's annual 420 event. And I'm also, as I said, this toolkit, once it becomes available in May, will be shared to other local and partner harm reduction organizations as part of our dissemination strategy. Thank you.
So next, I'd like to share some of the main findings and avenues to tailor the harm reduction youth messages. These elements were all raised across all focus groups: occasional users, regular users, French-speaking, English-speaking. So here are the three main findings, because we only have 7 minutes. So first, there's a demand for precise, concise, and factual information about risk associated with cannabis use, casual yet informative rather than a formal or medical approach. Inform about cannabis-related risk is necessary, but acknowledging the benefits users seek is as important. Here I must point out that even though cannabis was legalized 5 years ago, acknowledging the benefits that users seek remains difficult for media outlets, unlike alcohol, which is widely accepted and openly promoted. Second, terminology related to dosing, it was considered way too vague. Cannabis users may benefit from the message start low and go slow, as long as it is backed by a clear definition of what low means using a standard THC unit, and what slow means in terms of gradually increasing the dose. Define a standard THC unit is necessary and even crucial, I would say. And the last element, one of the lower risk recommendation is to buy from the products from the regulated market. But this advice was often or did not resonate with some of the participants, especially the regular users. They mentioned that there was a gap in this message because the 18 and 20 years old who cannot access regulated products are more likely to turn to unregulated sources. So I must point out also that in our province, it's the only province where legal age is 21-year-old, whereas we can drink at 18 and smoke tobacco 18, but only cannabis 21-year-old. So
1 minute left.
So other reasons for turning to unregulated market include cannabis products that are not available in the regular market, such as cannabis extract for vaping, and also the price. So we had to recognize the existence of multiple cannabis markets and mention that if youth were using unregulated products, they should start with small quantities and wait to feel the effects. So, perdón, la última. So just a quick finish. This is a quick overview of our project. You can use the QR code to go to our website. And I just want to point out and finish that this project is incredibly important for us, but harm reduction across Canada faces an uncertain future. Ongoing austerity measures and recent government changes have put pressure on funding and political support. And I will finish that tonight's federal election in our country, the direction of national priorities could shift, adding to the uncertainty of surrounding the future of harm reduction efforts. Thank you very much. Muchas gracias. Merci beaucoup.
Thanks a lot, Natalia and Laura. Our next speaker is Thomas Martinelli. Dr. Thomas Martinelli is a researcher at the Dewhirst Institute. He will discuss global developments in cannabis regulation and how harm reduction principles can be better integrated into policy reforms, drawing on case studies from Quebec, Switzerland, and Germany. He will highlight strategies to promote safer consumption and address barriers such as the political resistance.
Yes, thank you. I'm just going to stand up here because it's 5 o'clock, I know. Let's stay awake together. I'm glad that I'm after these ladies from Montreal because last year when I visited Montreal in Canada, I went to the SQDC, which is the state-controlled legal cannabis shop. And there I saw that cannabis was sold, it was used, it was produced without fear. There was no rushing, no hiding, just an everyday moment. And not too long ago, that same act could have led to arrest, to stigma, to shattered futures. But things around the world are shifting, slowly, imperfectly, but undeniably. And not just in Canada, but across cities and countries all over the world. Cannabis is stepping out of the shadows of punishment and cautiously into the light of regulation. So today I want to talk about why this moment matters. And not just for cannabis or for cannabis users, but also for the future of harm reduction. From Bogotá to Bangkok, from Berlin to British Columbia, cannabis policies around the world are opening doors for a broader vision of harm reduction. So I will start to explain where we are now in this moment, and then I will go to 2 arguments of why I think linking cannabis policies and harm reduction is important right now. And then I will finish with some arguments of how we can move forward. So recently we mapped and studied international developments in cannabis policy for recreational use together with RAND Europe. And there are now at least 43 jurisdictions that have regulated the supply of cannabis through law, with more announcing plans to do so. So we did not just study how these jurisdictions regulated cannabis, but also why. And I have a beautiful map, of course, that you've all seen before, probably in these presentations. Mine is also nice, I think. And I don't have time to go through all the countries, so I'm just going to skip through it a little bit. But these are all the places in the world where cannabis has been legalized or where there are plans to legalize it. And about these goals of the cannabis policies, because while there were many subtle and less subtle differences, almost all policies, they aim to protect public health and safety. And while not explicitly mentioning harm reduction, the current cannabis policies do breathe harm reduction principles. They aim to reduce the harms of prohibition, for example. However, the cannabis policies apply these principles to much broader domains than the usual harm reduction domains. At the same time, in the harm reduction field, there are increasing calls to broaden and transform harm reduction, calling upon harm reduction to expand its conceptualization. So I like the example of this paper, for example, saying harm reduction isn't enough. We should maybe look at mindful consumption and benefit maximization. So what if cannabis reforms and harm reduction principles would be linked more? Where can we go from there? So that brings me to my first argument. and that is that harm reduction is underutilized in cannabis policies. So even though compared to other substances, cannabis is relatively mild in terms of risks, as research and more evidence piles up, now that's easier to collect thanks to regulation, it seems that cannabis has more risks than we previously thought, particularly regarding addictive potential and negative long-term effects. So that's why there's also a need for safer consumption methods, safer product, safer behavior. And I have some examples of this. So for example, if we do not use combustible products anymore, as we've seen with vaping tobacco, maybe take the tobacco out completely. You can use extracts, safer products with limits on THC levels, for example. Edibles that are not attractive to children. We've also seen these in Quebec, beetroots with extractions. And maybe just quality control to cannabis, which is also safer, doesn't have any contaminants. And also safer behavior. You can think about educating people of combining cannabis with other substances. Cannabis and driving. How long does it take till the effects of cannabis have waned away, till it's safe to drive anymore? These are all areas in which harm reduction can complement the current cannabis policies, which around the world is not being done enough, I think. So the second argument is that cannabis reforms offer opportunities to anchor harm reduction deeper into drug policy. Recent cannabis policies, they give us something that we've been waiting for. New narratives to tell the story of harm reduction. These policies don't just talk about drugs. They talk about health. They talk about community safety, about human dignity. They offer goals we can all stand behind, not just drug users, but the whole society as a whole. And they allow to show that harm reduction isn't only about opioids. It isn't only about people who use drugs. It's about creating safer and healthier environments for everyone. So, to the way forward, because we have 7 minutes, we have to run. I'm just gonna go, yes. So, if cannabis can move from crime to care, then surely harm reduction can move from the margins to the heart of drug policy. But it won't happen by itself. If you want to anchor harm reduction more deeply into drug policy, we may not need new principles, but we do need new language. Thank you. It's time to shift from a deficit perspective, asking what can be reduced, to a benefit perspective, what can we build, and how we can promote empowerment, safer practices, and healthier choices, without always putting harm at the center of the story. So, and to go further, we need to connect harm reduction with other fields that share common ground. Criminal justice reform, mental health, recovery, welfare. Because I know harm reduction, we tend to preach for our own choir, you know, is what I'm doing today. But we need to also check out these other domains and work with them. So to conclude, in a broader sense, cannabis reforms, they can be an example of how harm reduction and drug use fit in modern societies through a holistic and truly balanced perspective. Or as Mr. Kojo Koram said this morning, drug policy can lead the way to a new way of policies, prioritizing people over profits.
Thanks a lot, Timothy. Very beautiful presentation, as you said. Very nice. Our next speaker is Dr. Timothy Dewhirst. It's professor from the University of Guelph, specialized in marketing and public policy. He will present critical insight into the role of tobacco industry in harm reduction narratives, focusing on how commercial interests often conflict with public health goals. His presentation is informed by internal industry documents and marketing analysis.
Thank you. It's certainly a pleasure to be here in Bogotá and Colombia. As just mentioned, I'm Tim Dewhirst. I'm a marketing professor situated at the University of Guelph, which is just outside of Toronto in Canada. Over the course of 7 quick minutes, I'm going to be talking and actually expanding upon what Anthony mentioned during the first presentation about the co-optation of harm reduction by big tobacco. But before proceeding, there are some disclosures that I should make. First, I've served as a frequent expert witness, as a marketing expert in tobacco litigation. typically on behalf of plaintiff counsel in class action lawsuits, as well as for governments where their policies in terms of marketing and promotion stipulations have been constitutionally challenged. Further, I'm the associate editor of the journal Tobacco Control, which is a British medical journal publication. And I've also done consulting for Health Canada, the World Health Organization, the Attorney General's Office in the state of California, among others. Okay, by way of introduction, harm reduction is certainly a movement that tends to be community-based, activism-driven, and concerned with human rights. It's certainly typically overseen by clinicians, nurse practitioners, as well as outreach workers. It's important to question with harm reduction about the various stakeholders that are involved. And certainly if we, and basically who is overseeing the harm reduction. Certainly when we turn our attention to tobacco harm reduction, it becomes particularly contentious about how involved the tobacco industry has been. So some examples of, there's a lot of marketing communication efforts, as well as public relation initiatives of major multinational tobacco companies like British American Tobacco or BAT, and Philip Morris International PMI, that really highlight harm reduction in the case of BAT, really equating it with their sustainability initiatives. And this is from their website. And then here we see an image from the website of PMI or Philip Morris International. Like the preceding slide, they often really highlight their scientists that are working at the company when they're talking about harm reduction. Now, certainly there is a place for harm reduction with tobacco if we can be convinced that the intervention is specific to existing adult smokers of combustible tobacco and getting them to switch to next generation products that tend to be highlighted by the tobacco industry, like nicotine pouches, e-cigarettes, and so on. However, when you look at the marketing communication of the major tobacco companies, they've certainly gone beyond existing smokers. And so there are a number of marketing communications, as you see here, that seem to have youth appeal, trying to draw new users to nicotine products. The ad that you see here is for Juul, their Vaporize campaign that circulated in 2015, 10 years ago. Had very youthful models, very bold colors. The product itself resembles a USB key, so it's very discreet. And it came in a variety of flavors, including creme brulee, which, again, seemed to have a lot of youth appeal. Soon after this campaign in the US, the FDA chief declared that there's a youth epidemic in terms of e-cigarette use. There's also a lot of marketing communication from the tobacco industry that really seem to encourage dual use. So it's not encouraging people to move away from combustible tobacco necessarily, but to use nicotine pouches and e-cigarettes when they're presented with contexts and situations where combustible tobacco use is not permissible. Here we see with blue e-cigarettes, it says, "Dear smoking ban," and you can see the woman very defiantly giving the finger to this notion of not being able to smoke. Here we have an Instagram post from an influencer, Christina, a woman that's based in Brooklyn, New York. It was identified as an ad for Juul, but she presented using Juul when she's in situations where she cannot smoke combustible cigarettes. So again, encouraging dual use. Certainly, if you look at the internal marketing planning documents from the tobacco industry that have been made public through litigation, we have an example here from Philip Morris during the 1970s, where they clearly recognized that smokeless tobacco products had a purpose of acting as a substitute for combustible cigarettes when people were presented with situations where they could not smoke, such as in bars and airplanes and other such situations. Moving ahead to the current year, 2025, this is a photograph that I took in Japan for BAT's product, a nicotine pouch called Velo, where again, they're really encouraging use of product when you're presented with situations where you cannot use combustible cigarettes, and again, seemingly encouraging dual use. And this is at the Narita Airport in 2025 in Tokyo, Japan. And you can see this ad again, presenting that velo can be used when combustible cigarettes cannot be. And the ad is actually, interestingly, placed right next to combustible cigarettes. And then there's also marketing communications that seems to be really discouraging making cessation attempts or quit attempts altogether. And here's an example of an e-cigarette ad from Blue where it poses a question, why quit? And within the ad copy actually says, no one likes a quitter. And so really discouraging, really discouraging trying to quit altogether. Here we have a series of slides that I'm going to show you that are BAT presentations that were made to investors and shareholders. And you can see that they were clearly identifying that their next generation products include vaping products in combination to tobacco was serving to actually grow the market and expand the market. And you can see that they identify here within UK that they were certainly going beyond just trying to appeal to existing smokers with their next generation products. Further still, here's another BAT slide made to shareholders and investors. And you can see in the year 2017, they were continuing to expand the nicotine pool and expand the market. And they were boasting that in 2017, they had added 8 million new users to be using nicotine products. Okay, so just further still talking about the growth opportunities. And so just in conclusion, certainly their marketing activities of the tobacco industry are trying to expand the market, which is contradicting a mandate of harm reduction. And 7 minutes was a lot to cover with this. So if you are interested in knowing more, I have spoken to this content in an editorial for the journal Tobacco Control. If you put my name, the title, it's open access, so it's freely available. You can get a lot more details than I'm able to provide here and now. Thanks.
Thanks a lot, Timothy. Our last speaker is Mazen Saleh, who will need to present by himself. I'm so sorry and apologize for this situation. It's not on my hands or your hands, but so you will need to present yourself, Mazen.
That is okay. I know more about me than maybe anybody else alive. Hi, everyone. First, I'd like to thank the conference organizers for all their past and continued efforts for a successful conference, and everyone really involved in bringing us here today, and to thank each of you for joining us today. I know it is late. It has been an eventful day, so I really appreciate you being here. So by way of a quick introduction, my name is Mazen Saleh. I'm a senior policy director at the R Street Institute, which is a think tank based in Washington, D.C. And if I can share that I've been living in D.C. for over 20 years. Right now, it's maybe not my favorite place to be, given the circumstances. So staying here in Bogotá is looking more desirable by the minute. But at R Street, I oversee our work on integrated harm reduction public policy. And what I mean by that is that our attempts to expand support for harm reduction while inviting policies to help individuals who smoke cigarettes. Our ethos when we talk to policymakers across the political spectrum in the US is that if you support harm reduction for one behavior, you should support it for all. And we do not deviate from this grounding. And it is within the spirit that my session today is focused on the tobacco and nicotine policy landscape for people who use drugs. Is there a presentation? Oh. I'll give it just 1 minute here. Huh? No, it's okay. I can do it without. To be honest with you, my presentation was only 7 slides. The first and the 7th were the intro and the email address, and the 5 were just graphics that I was hoping to zhuzh up a little bit. But I'm happy just talking real quick. While this is a US-centric presentation, the same measures to regulate tobacco and nicotine are shared by all countries. So before we dive in, I think it's important to discuss the organizing force behind global tobacco control. And I promise I'll be quick on that. The World Health Organization back in 2005 ratified a framework convention on tobacco control that we refer to today as the FCTC. It was a treaty that really established universal standards to regulate tobacco, which has since been signed by 168 countries, legally binding, and 182 ratified countries. In these pretend to infographics, you'll see the scope of the framework, which is quite comprehensive, and I'll talk about it a little bit. The universal standards for regulating tobacco can be witnessed in varying degrees at the national level. For the United States, we have stringent laws regarding product labeling, advertising, age restrictions, certain flavor prohibitions, federal taxation, things of that nature. But it is also within this context that I want to talk a little bit about how this affects people who use drugs. Among adults in the United States, roughly 12% smoke cigarettes today. In absolute numbers, that is about 30 million adults. However, among individuals that are living with opioid use disorder in the US, that number explodes to more than 75%. And in fact, more than half of the people in treatment for substance use disorder will actually die from tobacco-related diseases. If we are to take an approach focused on reducing harm, what does that look like in practice? And a number of my presenters today have touched upon that. But I think that to answer this question is really to realize that a lot has changed since the FCTC was created in 2005. Today, there are products that deliver nicotine without the devastating effects of inhaling burning tobacco leaves. Researchers refer to this as a continuum of risk. And the continuum of risk at one end has traditional nicotine replacement therapies like the nicotine patch, the gum, the lozenges, things that are usually prescribed to individuals who smoke to help them quit smoking. But also categorized at this lower end of the spectrum are e-cigarettes, nicotine pouches, products that heat but do not burn tobacco and therefore do not combust it. On the other end of the spectrum, the products that represent the most deadly products are all the combustibles, so cigarettes, cigarillos, things of that nature. It's important to note that at the lower end of the risk spectrum, those things that are not nicotine replacement therapies, so e-cigarettes, vapes, nicotine pouches, things of that nature, are not risk-free. They certainly have risks, and I want to be very clear on that. But they are certainly lower risk than combustible products. But the challenge facing governments worldwide is how do you regulate these products when the universal standards for tobacco regulation preceded their development and existence? Like many countries, we have multiple layers of regulation, one at the national or federal level, another one at the state level, and even more at the local level. Federally, the United States Food and Drug Administration is responsible for which products can be legally marketed and sold in the United States. It oversees product labeling and packaging. It holds companies accountable to marketing restrictions. It sets a federal age to purchase tobacco products to 21 across the entire country. And at the state and local level, lawmakers are doing more. They are moving to restrict certain classes of products. For example, they're looking to ban e-cigarettes or nicotine pouches, ban flavors, ban disposable versus reusable products, increase taxation, set maximum amounts for nicotine concentration in products. There's a lot of bans, prohibition, which we've seen doesn't work on a variety of things. But these inconsistencies end up varying from town to town and from state to state, reflecting a patchwork of regulation. Ooh, wow, okay. It's also reflected in the policies of mental health and substance use disorder treatment centers. Research published just last week by the U.S. Centers for Disease Control and Prevention found that among a sample study of about 10,000 mental health facilities and 15,000 substance use treatment facilities, less than 1/2 of the facilities offered nicotine replacement therapies to help people quit smoking. In fact, there are more vape-free policies that are reported in these facilities than there are smoke-free policies, which is astounding, given that e-cigarettes are a lower risk than combustible cigarettes. So to summarize, the folks that are seeking mental health or substance use treatment that cannot fully abstain from smoking or vaping, they usually cannot even get into the facilities. If they do get into the facilities, only about 1/3 offer the pharmacotherapy that they need to assist. And that is quite unacceptable. I think one approach to address the problem is risk proportionate legislation, which is develop policies that are correlated with the risks that they pose to an individual's health. And I will stop there, but can answer more of those in the Q&A. Thank you.
Thanks a lot, Mazen. It was really nice, and thank you to be so strict with the time. Now I invite you, all of you, to make questions. Please go ahead. No desaprovechen la posibilidad de preguntar. Así que, ¿quién va a ser el primero? Vamos por acá. Recuerden presentarse, de dónde vienen.
Gracias. Mi nombre es Aldo Contró, vengo de Ciudad de México. La pregunta es para Tomás Martinelli. Quisiera preguntarle si y qué tanto existen ejercicios o programas, ya sea a nivel sociedad civil o política pública, de análisis para las personas que tienen ya sea productos o cannabis y que puedan conocer contaminantes, concentraciones de cannabinoides y tener mayor certeza sobre su consumo. Gracias.
Yes. Thank you for the question. So I think the question was about if there are programs that look at contaminations of cannabis and analysis. Yeah. I mean, yes, they exist. And in different countries, it's arranged in different ways. So there are some countries that have the industry do this quality control. They have to control their own products, but there are guidelines on how they control it. In the country where I'm from the Netherlands, our institute, actually, the Trimbos Institute, we monitor what is being sold in coffee shops. So we report on contaminations. There was a report this year, actually. So yeah, they are definitely there, and I think they are important to keep the quality control there. Yeah.
Thank you. My name is Dr. Alex Wernick. I'm a retired doctor from Australia. My question is addressed to Professor Dewhirst. Thank you for your presentation. Given the extraordinary lethality of cigarettes, with 8 million deaths from smoking amongst 1.1 billion smokers around the world every year, 2 out of every 3 long-term smokers dying from smoking, each smoker losing an average of 12 years of life expectancy. And in contrast, we have about 10% of the nicotine market in the world now captured by manufacturers selling smoke-free products. We have 122 million vapors around the world. And we don't yet have a scientifically attributed death from any of the smoke-free options. And I'm referring here to vaping nicotine, not people vaping something that was vaping cannabis, which was contaminated. Given that, I would ask you, what would you prefer? Would you prefer a tobacco industry that is making a lot of money but kills 8 million of its consumers every year? Or would you prefer a tobacco industry that is making a lot of money but makes products that kill no one or kill maybe a handful of people?
Yeah, I guess my main position would be who is overseeing harm reduction. So I definitely see a role for these products, whether it's snus or nicotine pouches and e-cigarettes, for harm reduction. I guess what I would argue is that I would like to see a situation where a public health practitioner, such as a physician, being the one to advise the person of what is best for them. And so if they are a combustible smoker and do not have the desire to quit or have not been successful in their quit attempts, I think that there is definitely an important role for these alternative products if you can get that existing smoker to exclusively switch to those next generation products. But what I'm arguing against is that with the tobacco industry and all their initiatives in terms of harm reduction, I think it's largely a public relations exercise, because when you look at their communication and marketing practices otherwise, they're actually trying to expand their market, which is in contrast to harm reduction. And they're going beyond that existing adult smoker of combustible tobacco. So I guess to put simply, I'm just pointing to who is overseeing the harm reduction. There's definitely a role for these products with harm reduction, but I would like it to be the advice of a public health practitioner rather than the tobacco industry making that recommendation.
My country was world this requirement for medical prescription of vaping products. All other products are essentially banned in my country. And that was an abject failure, and it was abandoned last October.
Buenas tardes. Yo soy Ingrid de Brasil, toxicologista. Buenas tardes. Yo soy Ingrid de Brasil, toxicologista. Tengo una cuestión muy importante que me gustaría ver en discusión acá, porque en Brasil hay un problema. La Anvisa, que es el órgano de regulamentación, se lo prohibió el cigarrillo electrónico. Y ahora tenemos en discusión en Senado y Cámara de Diputados para leyes que vamos a hacer. Es muy difícil conversar con los políticos porque tenemos una división, soy contra o soy a favor. Y no son médicos en su gran mayoría, o biólogos o biomédicos o que sea. Entonces, la cuestión es, ¿cómo podemos conversar con estas personas y hacerlos entender o que en real es reducción de daños? Para que así podremos tener una discusión mejor para definir la ley. Esta es la cuestión. Gracias.
It's an open question. Anyone of the panel could answer it who feel like?
Yeah, I'll make an attempt. I can speak from the US perspective in trying to convince policymakers on the benefits of harm reduction across the board for any substance. And it really varies depending on the characteristics of the policymakers and the political realities that the messaging is going to be received in. Sometimes we will address it from a public health perspective, talking about lives saved, talking about the immediate kind of biomedical benefits that are received. Other times that's going to fall on deaf ears, right? And so we have to talk from an economic perspective. This is a cost-saving analysis. For every ounce of prevention, you have a pound of savings. And yet, even for others, we talk about it as a moral imperative. That if they are so supportive on the sanctity of life, then every life is included in that definition. And we need to figure out ways to kind of broach that, right? And so it really kind of depends who we're speaking with, what their values system is. But I think that there is no shortage of benefits and messaging that we can apply in trying to advance harm reduction in all of its forms.
Thanks a lot. Here we have another question.
Hola a todos, voy a hacer en español. Mi nombre es Arturo Escobar, soy de Brasil, Estoy acá por la Escuela Libre de Reducción de Daños y tengo una cuestión para adicionar un poco de complejidad en esta discusión de regulación de drogas, particularmente de tabaco, principalmente con esta conexión con reducción de daño que está cooptada por las empresas, por todo el negocio de las grandes compañías de tabaco. Mi cuestión es, mirando para la complejidad que necesitamos poner para entender las relaciones de las personas con las drogas, que es considerar el sujeto, considerar el contexto y considerar la droga, la biología, el organismo y su relación con la droga. ¿Cómo garantizamos, por ejemplo, leyes y regulaciones? La Ingrid está hablando que en Brasil estamos con los e-cigarettes prohibidos. Están prohibidos. Y tenemos algunas evidencias de que son menos nocivos que el consumo fumado de cigarros. Mas, ¿cómo podemos hacer entonces para demostrar que una persona, porque por algunos pocos casos que tuvimos de personas que se dieron mucho malo vaporizando el tabaco y tuvieron sus pulmones perjudicados por esto, como harmed, ¿ya? ¿Cómo podemos hacer leyes? Porque la reducción de daños es algo que se va muy específico en la persona, individual. Y la persona tiene todo ese triángulo, ¿no? Droga, sujeto, contexto. ¿Cómo podemos pensar regulaciones que sean capaces de también mirar para estas especificidades individuales que las personas responden a sus relaciones con las drogas?
It's an open question, so who want to take the word in the panel?
I want to talk to that, but I also want to say I think that how tobacco harm reduction and specifically harm reduction has been mischaracterized today, right? Harm reduction is not led by clinicians. It's not led by social workers. It's led by people who have lived and living experience. It's not led by policymakers or MDs sitting in offices. It's led by people who love people who use drugs. And that should be very clear. The fact, I'm sort of like not anxious, but sort of riled up a little bit. But tobacco harm reduction is not, as someone put it, inconsistent with harm reduction. It is not, right? Harm reduction and tobacco harm reduction, the core pillars and principles are basically aligned. If you take a look at the SAMHSA harm reduction framework and the principles, and I just pulled it up, right? The pillars of harm reduction and tobacco harm reduction, quite frankly, should be led by people with lived experience, embraces the inherent value of people, commits to deep community engagement. Everyone in here knows this, right? They know what harm reduction is. It promotes equity, but the most thing, it offers the most accessible and non-coercive support, right? And that's important when it comes to tobacco harm reduction, is that you are allowing, you are offering people alternatives to smoking combustible tobacco. And the last thing I have to say, and this sort of gets to your point, the last thing I have to say, like one of the core principles of harm reduction, right, is that the approach provides many pathways to well-being, right? And that well-being is sort of described by the person. By the person. If I want to smoke an e-cigarette, I should have the opportunity to do that. If I want to put snuff in my gums, I should have the opportunity to do that. And no one, not a government, should tell me I don't.
Thanks a lot.
And just one last, and I think we need to be very careful about how we argue marketing
and tobacco harm reduction, right? Those are two different arguments. And if you understand the logic behind arguments, you will see that that's the problem.
Thanks a lot. Really, really thanks a lot for your words. We have another question from the audience. Remember to tell your name and...
Buenas tardes, mi nombre es Francisco Ordóñez, represento a RDT Iberoamérica. La pregunta va para el señor Timothy. Me gustaría plantearle primero ante todo una reflexión y un par de preguntas. La industria de los vaporizadores existe desde hace más de 20 años y muchos de quienes somos activistas por la reducción de daños del tabaquismo comenzamos a utilizar estos productos mucho antes de que la industria tabacalera los incorporara a su catálogo. Desde entonces hemos promovido de manera independiente el uso de vaporizadores como una alternativa menos riesgosa para adultos fumadores. Sin embargo, en el debate público frecuentemente somos erróneamente vinculados con la industria tabacalera, la cual ha servido para relegar nuestra voz como consumidores y deslegitimar nuestra defensa de estrategia de reducción de riesgos y daños. Teniendo en cuenta esto, quisiera preguntarle, ¿cómo podríamos diferenciar de manera efectiva en el debate público y regulatorio la legítima voz de los consumidores que defienden la reducción de daños del tabaco de los intereses corporativos sin caer en descalificaciones automáticas? Y la segunda pregunta es, ¿qué mecanismos podrían garantizar que los usuarios adultos que promueven el uso responsable y la protección de los menores no sean excluidos ni castigados injustamente en las discusiones políticas públicas sobre los productos de nicotina de menor riesgo?
Microphone.
Thank you for your comments, and I agree with the comments that you've made. And if I refer to Canada, the country where I live and where I'm from, initially with e-cigarettes, there were a lot of independent vape shops where they, I think by and large, very much had the interests, like they were very genuine of trying to offer a harm-reduced product to those that were existing smokers, and I applaud and support a lot of their activities. What is unfortunate is that a lot of the major tobacco companies, through acquisitions, have basically, I mean, they've developed their own vaping products, but they also acquired a number of notable vaping products like Juul and so on, and they dominate market share in a lot of countries, including Canada now, and many people, when they're going for vaping products, are going to convenience stores now as opposed to these independent vaping shops, and I think that's unfortunate. And so what I was speaking to was big tobacco. I wasn't speaking to what's being done by independent vaping retailers, and I mean, these were major e-cigarette and nicotine pouch brands that are, you know, produced now by major multinational tobacco companies. So there's definitely a distinction there to be made.
Hi, good afternoon. My name is Ria Tsinis. I am a co-founder of the Academy of Perinatal Harm Reduction. I'm from Portland, Oregon. My work focuses on perinatal harm reduction, so pregnant and parenting people who use drugs. And you know, there's a dearth of information about smoking and pregnancy, aside from just don't do it. And so I'm just wondering if you have, I mean, aside from, you know, we know all of the evidence is about the harms of combustible tobacco, and largely even that could be correlated to social determinants of health. So I'm just wondering if you have seen or heard of any more research regarding, you know, harm reduction efforts in pregnancy, and if you see a possibility where I know, like, you can get prescribed patches, nicotine patches and such, if vaping or those types of interventions might be able to be prescribed for pregnant people as an alternative to combustible tobacco as a harm reduction intervention for people who, because like I'm a smoker, and the hardest thing for me is to not do the hand to mouth thing. Like the patch, that's why it's hard. The patches don't work for me because I like, you know, the actual act of smoking and inhaling. So I'm just wondering if, you know, if there's any new research that you're aware of, and if there are any interventions like that that you might be aware of, or any resources that you might be able to point me or the population that I serve to. And thank you. Thanks.
It's an open question. Anyone that have some information about it?
Yes, so we pulled together, I believe, some research at the R Street Institute around e-cigarette use and pregnant people. I'm happy to connect with you after this session. It is impossible in the US to get prescribed a vape because e-cigarettes would need to go through a regulatory approval process in which they would certainly be rejected given the bar that is set for medical devices and medications. That being said, we have anecdotally heard of physicians presenting their patients' information around this continuum of risk of products and around some of the safety and efficacy around their use. But I would, probably agree and sympathize in the sense that public health research on pregnant individuals is lacking.
Thanks a lot. Badly, we are running out of time. There is a lot of people asking me from the mic. I'm so sorry we won't be able to finish all the questions. I have 2 more online. Maybe we will go for a third one. So I'm so sorry. Maybe we will take like 2 or 3 minutes more. But for the rest of the people that it's asking me late the mic, I'm so sorry. There is no way because we're running out of time. Here is another question.
Thank you. My name is Jeffrey from Costa Rica. To the gentleman, I'm sorry, I think I forgot your name, from the National Harm Reduction Coalition. Excuse me? Anthony, thank you. Currently the big tobacco companies hold a market share of around 25% in the US of their complete market share. And it's a product that is, the big tobacco entered like 11 years after it was developed by a Chinese pharmacist. And on top of that, we have a bunch of information and knowledge regarding the science available. For example, the Cochrane Living Systematic Review that have 44 random control trials. We have the 8th annual review of evidence from Public Health England, now called differently, but it was traditional Public Health England, with around 400 studies. And there's a lot of information already. So we kind of know that it's already less harmful than regular compostable cigarettes, right? So the idea of being and you said, and I understand that some people actually are feeling scared that it's something from the tobacco company, but I don't see it quite there, how to be scared of that. For example, if big tobacco starts manufacturing Narcan or naloxone, it doesn't lose its harm reduction potential, right? So what are we afraid of?
I think that how we just need to increase our education, tools, and engagement, right? There's a lot of misinformation and disinformation about tobacco harm reduction, and really harm reduction in itself more broadly. And so NHRC, with a grant from Global Action to End Smoking, we're going to take for the next 2 years a focus on developing educational tools, specifically geared for or crafted for syringe service workers or staff. And specifically, we have a sort of model on how to provide technical assistance and capacity building so that organizations can use that framework to educate their staff. First knowing or assessing the level of knowledge that their staff has for tobacco harm reduction, and then crafting a way to increase the education of the staff with tobacco harm reduction, outlining an implementation plan for SSP participants. So you can roll that out. One of the things, though, that's vitally important is that when we talk to SSPs about tobacco harm reduction, one of the things that they say is that's great, we are on board, but are you going to offer us resources, right, so we can purchase, store, do the logistics to get products in so we then can share them with project participants in addition to sustaining that over time? Because SSPs don't, Sharia service programs don't have the financial capacity to take that on, right? And neither should we expect them to do that, right, when they do not necessarily have that capacity right now. But the hope is within 2 years, we would start to make movements where there's a lot more discussion about tobacco harm reduction within the traditional harm reduction space.
Just to answer maybe a public health perspective, I work with youth, and what we are scared of is vaping vaping prevalence that has been gone up. It was almost nothing, and now we're 20% of youth, 15, 17-year-old, who vape. I mean, these are our data from Quebec, at least, and my city. So I think this is what, at least, if you ask what's our, main worries about big tobacco, is that is one of, at least my perspective for youth, that I see that there weren't. It's not a transition of a mode of consumption, but they're all new users, and also having cannabis. So it's a mode of consumption, and again. If you vape cannabis, usually it's extracts, and they're very, very high, very potent. So that I could just share my worries. But I would not necessarily at all disagree that harm reduction is needed for adults and substance users. But for youth, I'll just add this information.
Well, we are totally run out of time. We don't have time for more questions, but I was asked, someone want to share something that is very important, and I think it has a lot to do with actual times, especially here in Latin America.
Muchas gracias, Ignacio. No es una pregunta, quiero compartirles una preocupación y una reflexión. Vengo de México, los vapeadores han sido prohibidos a nivel constitucional. La forma más riesgosa de administrarse nicotina, lo sabemos todos, es a través del tabaco combustible. Hoy, cualquier persona que quiere vapear o que requiere vapear para administrarse nicotina y no lo quiere hacer a través del tabaco convencional, está incurriendo en una ilegalidad. Hoy, todos los vapeadores se tienen que conseguir en el mercado negro, no en el mercado gris, en el mercado negro, con los consecuentes riesgos a la salud, porque ninguna autoridad sanitaria va a verificar la calidad ni del dispositivo ni de los líquidos. Somos el primer país del mundo que los prohíbe a nivel constitucional. Yo espero que seamos el único país del mundo que cometa esta barbaridad desde la perspectiva de la salud pública. Eso es todo. Gracias.
Muchas gracias. Lamentablemente se nos acabó el tiempo para poder hacer más preguntas. Le pido disculpas a las personas que no alcanzaron a hacer sus preguntas. Antes de hacer el cierre, me gustaría pedirles a todos y aprovechar la oportunidad. Es primer año en que hay personas que están vinculadas a la reducción de daños del tabaco en este evento, lo que me tiene muy alegre, pero quizás en estas sesiones donde tienen más posibilidades de conocerlos y hacer networking, los invito a recordar que este tipo de eventos es para conocernos y poder trabajar de mejor manera en conjunto. Así que aquellos que estén interesados en conocer a activistas de esta nueva línea para este tipo de eventos de reducción de daño, los invito a quedarse y preguntar quiénes son, de qué países, probablemente vengan incluso del mismo país y se puedan ayudar juntos. Voy al cierre, les agradezco en todo caso. Quiero agradecer una vez más a todos nuestros oradores por compartir sus conocimientos y experiencias, y a todos ustedes por estar aquí hoy. Esta sesión nos mostró que la reducción de daño no es solo una teoría, sino un movimiento vivo, hecho por personas y para personas. Y cada voz cuenta en este camino. También quiero agradecer especialmente la apertura de este espacio para integrar a la conversación la reducción de daños del tabaco, es un paso fundamental para construir una agenda más inclusiva y efectiva en nuestro movimiento. La reducción de daños no solo es una estrategia sanitaria, es también un acto de dignidad, de justicia y de compasión. Porque la reducción de daños trae luz donde hay oscuridad, trae salud donde había enfermedad y esperanza donde antes solo había desesperanza. Sigamos caminando juntos, sigamos construyendo puentes y no muros, sigamos poniendo a las personas en el centro. Muchas gracias y de verdad espero que disfruten el resto de HR25. Gracias.